Okay, I think it is time to start. So I will say something in Turkish, less in English. Then I will give the word to İlgin and he will speak a little bit more. Evet, Türkiye'deki herkes için iyi öğleden sonralar diliyoruz. Çok alışkın olduğumuz bir laf değil ama Türkiye HPB Cerrahi Derneği'nin düzenlediği bu webinara hoş geldiniz. Ben Kaan Karayalçın. Bugünkü webinarın konusu Cholangiocarcinoma ve iki çok önemli merkezden çok değerli iki konuşmacımız var. Evet, ben sözü İlgin'e bırakıyorum. Türk Hepatobiliyer Cerrahi Derneği Yönetim Kurulu Başkanı. İlgin, söz sende.
Thank you. As the president of the Turkish chapter of the IHPVA, we are honored to host two very distinguished guests to speak on the topic of cholangiocarcinoma. I've had the pleasure of training with Professor Ebata 20 years ago in Japan at the first department of surgery, Professor Yuji Nimura's department. At that time, Professor Ebata was a fellow, a very academic surgeon with a bright future, so it's no surprise that he became the professor of the department 20 years later. Watashi no Nihon de no 14ヶ月は色々な意味で忘れがたかったです。全く違う文化と考え方を持つ人々の間で生活したということは自分自身大きく成長させることになったと思います。It was a wonderful 14-month period which expanded my horizons and taught me a lot as a person, as a physician, and more importantly, as a person. Welcome, Professor Ebata. I've had the honor of meeting Professor Guglielmi in Japan again about 6 years ago. We are very well aware of his excellent studies, and we are honored to meet him today in person to ask our specific questions and consult on specific topics. My Italian is very skimmy, so I just have to say Forza Italia and transfer to Professor Karayalçın. Thank you.
Evet. Sayın İlgin Özden'e teşekkür ediyoruz. İki önemli merkezden iki önemli konuşmacımız var dedik. Sayın Ebata, Profesör Ebata Nagoya Üniversitesi'nden. Nagoya Üniversitesi biliyorsunuz önemli bir HPB merkezi. İlginle yaşlarımız yakın olduğu için biz Profesör Nimura'yı ve Profesör Nagino'yu canlı dinleme şansını bulmuş nesildeniz. Şimdi de Profesör Ebata o bölümün başkanı. Gene Sayın Alfredo Guglielmi Verona Üniversitesi'nden. Verona Üniversitesi de gene HPB dünyasında çok bilinen, özellikle de pankreas cerrahisinde çok önemli bir merkez. Her ikisine de teşekkür ediyoruz. Ayrıca bu toplantının organizasyonunda bize yardımcı olan Uluslararası İASKO'ya özellikle de teşekkür etmek istiyorum. Şimdi sözü Profesör Ebata'ya bırakıyoruz. Yes, Professor Ebata.
Yes.
We can start.
Okay. Thank you so much for inviting me to this great conference. And Turkish surgeon, I have a sympathy of Turkish surgeon because of the Japan-Turkey friendship for a long time. Thank you so much for inviting me again. Can I share the story first?
Sir, can you turn the volume of your microphone a little bit? It is a little bit difficult for us to hear you.
Pardon. Can you see my slide?
Yes, we can see.
Can see. And can you hear me?
We can hear, but with a little bit difficulty. At least for me, I'm not.
More sound is small.
All the participants. İlgin, can you hear it? Okay.
Oh, okay. Your sound is very good. Sorry, I check.
It's excellent now.
Now, okay.
Yes.
Yes. So I start my presentation. Yes, this is my first slide. I'm very honored giving me a chance to talk here. And patients with perihyoid cholangiocarcinoma often have advanced tumor at initial presentation. We know that, but in reality, we have very few data about so just a moment. With data about tumor stage proportion. I show tumor stage proportion in 239 patients in Nagoya University Hospital. Recent 10 years, we accept 739 patients with perihyoid cholangiocarcinoma visited in Nagoya University Hospital. As expected, bismuth type 4 tumor is the most common and followed by bismuth type 3 tumor. And according to Brungart system, Brungart T3 tumor is the most common tumor type. And AJCC T4 and T3 tumor is a very common tumor. So management of such advanced tumor is a very common practice as biliary surgeon. So in this cohort, 33 patients are judged as unsuitable for surgery due to distant metastasis, locally advanced disease, or poor functional reserves of the future liver remnant. And the remaining 497 patients underwent resection, giving our resectability rate 67%. Of them, vascular resection, this is a non-vascular resection group, and 39% of patients received their vascular resection, 20% portal vein resection, and the hepatic artery resection alone 6%, and both resection 30%. We performed about the complex hepatectomy with vascular resection in about 40% of the patients. So my today's topic is very simple: indication, technique, and outcome about vascular resection, portal vein resection, hepatic artery resection, or both resection. This is a photo, intraoperative photo, just removal of the specimen. And increasing technical demand is practice. So general aspects of portal vein resection is summarized here. Portal vein resection is done when we find gross involvement of the portal vein during surgery, and it's usually performed after completion of hepatectomy. Type of resection is mainly segmental resection. And the reconstruction have some variation into end anastomosis or patch repair of a rare interposition graft. But suturing technique is similar in any types. Anticoagulant is not given routinely during surgery, but AT3 is sometimes given recently. Let me show the first video demonstrating a basic technique in end-to-end anastomosis. This technique has not changed over 30 years since ex-Professor Nimura started portal vein resection. Sorry. So this process is right. Right hepatic trisectionectomy with portal vein resection. This video starts after completion of the liver transaction. After divide the bile duct, we press the vascular pumps suitably and cut the portal vein. And the specimen removed here. This is the 6-0-prolene with a C1R. We press the 2 end stitch like this. And start the suture. The posterior O is intraluminal technique. About 1 millimeter radius and 1 millimeter radius and interval. And then the suture is changed to the anterior wall with over and over technique. Yes, finally, we saline flushes performed like this and stretch the anastomosis, and vascular clamp is released like this. Some growth factor is pressed here, and then anastomosis is finished like this. This is a post-hepatectomy. We usually perform the portal vein resection and reconstruction after completion of a hepatectomy, and as a good view. The second video shows interposition graft using the right external iliac vein. We prefer right external iliac vein for interposition graft. This is a right HPD case, and the video started another incision of the right lower abdomen. This is the initial incision. This is second incision for graft harvesting. This is right iliac artery, and this is a right external iliac vein. We get about 3 centimeter size iliac vein. This is a removable here, and the sutures here. This is a portal vein, and this is pancreas splenic vein. The tube has a wide invasion of the main portal trunk, so we need an interposition graft. This is pancreatic. You can see the pancreatic stump. The first with the hepatic side anastomosis using the same technique. Stretch the internal lumen and additional stretch by flush. Adjust the length, and the second anastomosis is performed. This part is a segmental interposition graft. And for successful portal vein resection reconstruction, we must avoid kink, twist, stenosis, or thrombosis of the portal vein. For this sake, we have to pay attention to the following points. Press vascular clamps parallel to the axis and distantly from the anastomosis in both sides. This also makes sutures easy and resect the portal vein with appropriate margin and angle, and stitch uniformly and carefully. Not to hook the opposite side. Tie growth within with satisfactory growth factor. We keep this point in any types of the portal vein resection. After compression of the portal vein anastomosis, we have to take care of the portal vein status. We carefully inspected the appearance, moving the future liver remnant. We often palpate the anastomosis to check the portal pressure and thrombosis. And we also check the portal perfusion with S. Importantly, we don't hesitate to redo anastomosis when it seems not so great or uneasy. I'll show an actual case. The patient underwent a right hepatectomy, caudate lobectomy with portal vein resection. Unfortunately, I redid portal vein anastomosis 2 times additionally. I'm afraid to say this is a bad, but instructive example. I'll show it. This is a fast reconstruction. But you can see the twist, rotation of the portal vein. So this is probably this leads to thrombosis. So we re-anastomosis like this to adjust the rotation. Reject the anastomosis. And this is the re-anastomosis, but we can see the little bit stenotic, and the ultrasound reveals hyperperfusion. So redo anastomosis is planned. The vascular clamp direction is a little bit different. This is ventral to dorsal side, and carefully stitch. This is a third portal vein anastomosis. This is a satisfactory outlook and a good portal perfusion. So this is a final anastomosis. So sometimes we need re-anastomosis of the portal vein. This is a case of intraoperative portal vein thrombus. The blue tape stayed here during the following video digestive anastomosis. I catch the candy film, gummy candy feeling of the thrombus at the portal vein. So you can see a typical thrombus here. So I did cleaning using a balloon catheter and re-suture like this. So we have to find the portal thrombus if the thrombus occurred intraoperatively. And this is a post-operative portal vein thrombosis on day 7. The CT scan shows a completely portal vein thrombosis like this. Anticoagulation therapy using 83 and heparin dissolved the thrombus successfully, but very risky complications. So it's a complete obstruction of the future liver remnant. Portal vein complication occurred in 10% after portal vein resection and 5% after without the portal vein resection. During the post-operative period, it's 6% and 2% portal vein thrombosis is found. Accumulating mortality this is a graph of the accumulating mortality according to with or without postoperative portal vein thrombosis. Surprisingly, the 90 days mortality reached as high as 25% in patients with postoperative portal vein thrombosis. This portal vein thrombosis is an infrequent but risky complication requiring specific management in the biliary surgery. The next topic is hepatic artery resection. The right hepatic artery is an exclusive site of resection during left-sided hepatectomy. Simultaneous resection of the right hepatic artery and the portal vein is very common rather than right hepatic artery rejection alone. And the most complicated procedure, left trisectionectomy with double vascular resection, is needed for advanced tumor. The technical timing is also overlap with the portal vein resection, but the attending doctor who performed the hepatic artery reconstruction is different from the portal vein resection. We outsourcing this to the plastic surgical team who are specialized for microvascular surgery. And the main technique is end-to-end direct and motion followed by the transposition of the major another major arteries, gastroduodenal artery or left gastric artery. And sometimes we use interposition graft with the right radial artery. And the technique, plastic surgeon technique, the interrupted suture and the microscopic view with 90 nylon. And it takes about 30 minutes, including preparation. This is one example of the left hepatectomy with right hepatic artery resection. The lymph node is completed. Lymph node clearance is completed. This is a left portal vein. The patient has a right hepatic artery invasion only, without portal vein invasion. This is a limit of the dissection of the right side of the portal vein. We take, this is the right side of the right hepatic artery. This is a posterior portal vein here, and right hepatic artery here. The left liver is completely removed from IVC, and the liver transaction is studied like this. This is a middle hepatic vein. After compression of the hepatectomy, the bile duct is divided. And this hepatic margin is tumor-free. And finally, no, this is right hepatic artery resection. And finally, left hepatic vein is divided. You can see the right hepatic resection and interposition graft is prepared like this. This is a radial artery. And this is a plastic surgeon technique, interactive suture with 90 suture. Sorry, it's very a bit wrong. This is another side of the anastomosis. And I want to show the, unfortunately, this patient has an obstruction of the reconstructed hepatic artery. After biliodigestive anastomosis, completely obstructed. So the anastomosis, redo anastomosis performed like this. This is the final figure, and successful anastomosis was completed. And this is another video, very short video, left trisectionectomy. This is a right hepatic artery invasion, but unexpectedly we found a portal vein resection, so we converted both vascular resection in this case. This is a demarcation, right? Because of the we performed the portal vein embolization. And the repair transaction is studied along the right hepatic vein. And we can reach the right pedicle, portal pedicle, and taped right posterior artery. This is an anterior artery, and this is second right anterior artery. The patient has two hepatic arteries. We divide some of the part is divided, and right anterior portal vein is taped like this and divided. This is invasion of the hepatic artery and the portal vein. The last step of the hepatectomy is about both like this. Hepatic artery is divided, and next hepatic vein is divided. So portal vein invasion. Finally, we pressed vascular clamps, and the portal vein is divided. This is a compression of the rejection phase. Portal anastomosis is finished, and now this anastomosis is hepatic artery anastomosis is studied now. So sorry. So this is a long-term outcome after vascular resection. I reported about 15 years ago. I reported a long-term result after portal vein resection. This is a this figure shows the portal vein resection, and surprisingly, the 5-year survival rate is only 8% at this period. 2003. And the caution should be paid. Foot-related surgery indicates about 10% hospital death was excluded in this graph. So the actual 5-year survival rate with portal vein resection is very, very small, smaller than 8%. And this is the updated result, including all deaths, is shown here. We recently reported, no, sorry, this is 2003, not 2003, 2020. The updated result shows survival rate after vascular resection is 27%. Without vascular resection, the survival rate reaches 50%. When the vascular resection is divided into portal vein and hepatic artery resection, the both did not significantly differ. 30% in hepatic artery resection case and 25% in portal vein resection case. These updated results support the resectional strategy for advanced peripheral cholangiocarcinoma. So this is a summary of my talk about hepatectomy with vascular resection for peripheral cholangiocarcinoma. This technique works as a key role to expand surgical indication, particularly for type 4 tumor. And I highlight here importance of a specific management and technique about the vascular resection. And improving long-term survival suggests a rationale of vascular resection for such advanced tumors. Thank you for your attention. Thank you so much.
Thank you, sir, for this excellent talk. There are a couple of questions from listeners, but I want to ask a short question. We have been listening your results for a long time at Nagoya University, but unfortunately these results cannot be repeated in the Western world. The Western surgeons are reluctant to do vascular resections as you do. So is there an explanation for this from you? A simple answer?
Yes, reliability and yes, I have a same impression about this technique. Because of this technique, Nagoya University Hospital, the result of the Nagoya University Hospital can be done in Japan, another hospital. For example, a National Cancer Center Hospital or the Cancer Institution Hospital in Tokyo shows the same result of our. So the objective is the same result can be reached, but management, not about technique. Preoperative management is completely different between Western and Japanese style. So this, I think this is a major cause. For example, recently the Dutch randomized study about preoperative drainage for peripheral cholangiocarcinoma indicates a very high mortality, 33% mortality in PTBD case. In this Dutch study, PTBD is still the mainstay of the first line biliary drainage approach, but now in Japan, it's not the endoscopic biliary drainage is the first line approach. And second is portal vein embolization. We prefer to use portal vein resection before extended hepatectomy. So this difference of the preoperative management affects outcome between the Western and Japanese. I think this is my plausible answer.
Thank you, sir. Now I will take the questions from the audience or the participants. Ahmet Çoker, who is a close friend of me, so I will give priority to him. His first question is, what is your contraindication to perform this operation rather than distant metastasis and patient-related reasons? So,
yes, indication of this vascular resection is very important, I think, because of this type of complex hepatectomy, the mortality after this extended hepatectomy is very high, also in Japan, because of the nationwide survey in Japan revealed about 5 to 10% mortality after extended hepatectomy with peripheral cholangiocarcinoma. So we think patient selection is very important. And Of course, distant metastasis tumor staging is the first consideration. Distant metastasis is also contraindication of the surgery, and far advanced, locally advanced GC. These definitions are a little bit difficult in detail, but for biliary extension, the limit is right limit. The right limit is the right portal vein ramification. This is a limit. And the second limit is the left side of the umbilical portion. When the tumor reaches both limits, it's locally advanced. And the second locally advanced factor is vascular component. It's, I mean, the reconstruction is when the reconstruction technique is very, very difficult. This is a contraindication. So the indication of the locally advanced tumor is different between institution, surgeon institution, or region. So this is a very difficult problem. And I think some of the population are indicated for liver transplant, probably. This is my second answer for locally advanced tumor. And the general consider liver function, this is the third indication associated with liver function reserve. This is also the difficult problem and different between the Japanese, Asian, and Western countries, because Asian people likely to use induction ICG test for determination. This is another difference. So the Japanese style in indication of the liver function reserve cannot be routinely used in Western countries. You use an ICG test routinely?
No. It's not very common in Turkey. I think Ilgin used it in Japa when he was in Japa. I don't know if he's using it now, but it's not very common in Turkey. Okay, thank you, sir. I think that was the answer of second question from Ahmet Çöker. So we move to another question. There are concerns about external iliac vein grafts. Do you have any morbidity related to the leg after using that graft? And what happens to the patient's leg?
Yes. We are sorry to say we have no experience of another interposition graft. So I cannot compare to another style of the interposition graft. I know the Professor Miyazaki, you prefer to use left renal vein graft, and some guy use this graft.
Interjugular.
Yeah. But I have no experience about this, so I'd like to know the comparison feeling of the professor, other professors or other guys.
Okay, thank you. And another question. Do you do vascular reconstruction always after the hepatectomy? Or is there any other preference?
Yes. Nearly all patients receive the anastomosis after hepatectomy, but few patients receive the prior to hepatectomy because of these patients did not receive the portal vein embolization, so the inflow is continued. So in this patient, we performed the portal vein resection and reconstruction before hepatectomy. But in usual case, we perform the portal vein embolization, so the portal flow is completely stopped. So we prefer to use portal vein resection and reconstruction after hepatectomy.
Okay. So is there a place of liver transplantation for hilar cholangiocarcinoma? What do you think
Yes,
about?
I believe it. I have no experience of the liver transplantation, but and I think a small population of the perihilar cholangiocarcinoma benefit from liver transplantation because of the limited tumor. But some patients with limited tumor also have a poor liver function result. In these patients, is a good candidate of liver transplantation. And another candidate of the PSC associated cholangiocarcinoma. In this patient, we cannot determine, we cannot get accurate staging biliary along biliary extension. So in these patients have also a good candidate of liver transplantation. But caution should be paid advanced tumor. For example, vascular rejection. In these patients has a nodal metastasis with an incidence of 75% or more. So the vascular rejection with is not a good candidate for liver. Such a deep vertical extensive vascular invasion is not a good candidate for liver transplantation. This is my personal opinion.
Okay, thank you. What do you think about ALPS procedure for hilar cholangiocarcinoma?
I totally disagree with ALPS approach because
You'll need to say more.
as you know, the ALPS approach needs a liver transaction. Some, not why, but liver transaction. This liver transaction always triggers viral injury and infected viral contamination. So theoretically, ALPS approach is not good approach, not good or dismal approach for hilar cholangiocarcinoma.
Okay.
This is not for liver tumor. It's a good, maybe a good approach, but biliary tumor with infected bile usually with bile contamination after biliary drainage. In such case, it's a contraindication because the patient has a potential infection.
Okay, last question. What is your anticoagulation policy after vascular reconstruction? Artery and vein, are they same, or do we have a different policy for the artery and for the portal vein?
Yes, since 2010, we usually use anticoagulant 3 to the patient when the level of the AT3 level less than 50%. This is our indication of the anticoagulant therapy, but not use the heparin, systemic heparin administration. This is my simple answer. AT3, we use AT3, only AT3.
Okay. I said last question, but another one. Do you use portal vein arterialization?
No, never.
Never.
We don't like it. and portal vein resection and reconstruction must be done appropriately.
Okay, thank you.
Thank you.
Thank you very much, sir. Now we are moving to next presentation, Professor Guglielmi. Am I pronouncing your name correctly? I'm not sure.
No, it's correct. It's correct. It's correct.
Okay.
Thank you.
Please start, sir.
So, can you see the video? Yes. Okay. So, first of all, I want to thank you, to thank Ender, the dear friend Ender, and to thank Ozden for this kind invitation of the Turkish HPV Society. Thank you very much. The topic of my talk is the surgical treatment of intrahepatic cholangiocarcinoma. When we approach cholangiocarcinoma, intrahepatic cholangiocarcinoma, we face usually with a single tumor, big tumor, because we do not have a screening policy in our country. So usually we found big tumor, huge lesion like this, in no normal liver, without cirrhosis and without disease, and usually without preoperative chemotherapy. The main prognostic factor after resection are well known: the size, lymph node status, radicality of the surgery. The size, more or less than 5 centimeters, had a double survival at 5-year survival, 50% against 25%. Lymph node status is one of the main important prognostic factors, and the radicality of surgery. The aim of the surgery of this disease is, like in other cholangiocarcinoma, is to obtain radicality with surgery, R0 resection, that you can obtain more in almost 55, 50 or 90% of cases. To reduce mortality, we have to face with normal liver, so the mortality is a little bit lower than other patients. Sorry. And to obtain good long-term survival, to reach almost 30–40% of mortality, 5-year survival. So my topic is what debate about some controversies in the treatment of this disease and new trends in the treatment of this disease. The controversies debate is the treatment of multiple nodules, T2, according to the 8th edition of ACC, and how to treat the T4 lesion with invasion of perihepatic structures. The third controversy is the role of lymphodenectomy in this disease and how have to manage the recurrence of this disease. New trends, laparoscopy, and new chemotherapy regimens. The first controversies, what have to do with multiple nodules? We studied which problem and we classify the T2 tumors in single plus satellites, with the satellites that is located in the same anatomical liver segment, and real multifocal tumor with multiple nodules in different anatomical liver segments. We are a little bit critics on this classification because, in our opinion, these tumors do not have the same biological behavior. So it's difficult to accept that this is T2 tumors and this is T2 tumors. And if we analyze the results of this classification of multifocal nodules, this is a multicentric study on 250 patients, you can observe that the best survival curve is obviously in single tumor. In satellites, that mean nodule in the same segment, you have good result with resection. In multifocal, the result is very bad. We have to observe that also in multifocal, the result is very low, but better than in non-curative treatment. And another problem is if we have some association of negative prognostic factors like lymph node status and radicality, we have to consider with very attention the indication of this patient. So multifocality with other negative prognostic factors may be a contraindication to the treatment. And then we can consider adjuvant or neoadjuvant chemotherapy treatment. You can see here N positive and R1, the curve of survival is very bad. This is an example of multifocal ICC that at the beginning of our observation, we consider unresectable. This patient was submitted to chemotherapy, cisplatin, gemcitabine, and according to the very, very good response of this case, of this patient after 9 cycles, we decided to submit this patient to surgery, combining atypical resection of this nodule and thermoablation of the nodule in the center of the right lobe. And in this case, it is a case that considered the good response to chemotherapy with the selection before surgery. We had a follow-up disease at 12 months. There is no recurrence of disease. You can see here the nodule that treated with radiofrequency ablation. But we have to consider this case with very critical selection. The second controversy is the advanced tumor, T4 tumor, that involve extrahepatic structure. We can have vascular involvement of vena cava or portal involvement. And we have also resection of adjacent organs. I mean diaphragm, adrenal gland, bile duct, and so on. To treat this stage of the disease, we have to consider major hepatectomy or extended hepatectomy. Here you can see an example of a big cholangiocarcinoma involving segment 1 with infiltration of vena cava that we operate with enucleation, with the resection of segment 1 and the reconstruction of vena cava. What is the outcome of vascular resection, of portal vein and cava resection in this patient? This is the results of Italian and international cooperative study. And you can see that the resection is still, radical resection is still high, 74%, about 70%. The post-operative mortality with no resection is low, 2.5, but is very high when you resect portal cava and with 12% of mortality. And what about survival in this patient? Of course, with no vascular resection, we have the best survival with the 38% at 5 years survival. With cava resection, we have 30%, and portal vein resection, we have 22% of survival. But it is very interesting to observe that if we combine vascular resection with favorable prognostic factor, with R0 resection and negative lymph nodes, we can obtain a very good survival, for about 50% of survival, and we do not have difference in survival between vascular and non-vascular resection, but the condition is to obtain R0 resection and to have no lymph node involvement. Vascular resection with other negative prognostic factor, R1 resection and positive lymph node, have a not so good survival, 20% of survival. And what about the resection of adjacent organs? I mean, diaphragm involvement, like in this case, that we do a resection of a diaphragm, or adrenal gland involvement. In this case, we perform a resection of the adrenal gland and block with the right lobe in this case. So if we have the extended surgery in visceral resection, that means that the disease is go in the peritoneal cavity, and so the survival is not so good. You can see here the results with no visceral resection, 40%, and with visceral resection, 8% of survival. So in this case, you must do a very clear and careful selection of the patients. The second controversy is the role of lymphodenectomy. We have to stress that the positive lymph node in intrahepatic cholangiocarcinoma is very high. You have about 33% of positive lymph node in regional lymph node and up to 10% of lymph node in extra-regional lymph nodes. So in our opinion, according to Japanese opinion, we consider the lymphodenectomy mandatory. This is not so widely accepted. You can see here the National Cancer Database of United States, and you can observe that almost 40% of the patients do not have lymphodenectomy. The curve of this survival in this group of patients is between the negative lymph node and positive lymph node. But the problem is that this group of patients is not well classified. You do not know the stage of this patient. So we recommend a lymph node dissection. We recommend the lymph node dissection also in small cholangiocarcinoma. This is a multicentric Italian study. And you can see in small, less or more than 3 centimeters, that also in small cholangiocarcinoma, we have 1/3 of the patient with positive lymph nodes. And in large, about 40% of the patient with positive lymph nodes. And both in large and both in small intrahepatic cholangiocarcinoma, the negative and positive lymph nodes is very strong and significant prognostic factor. You can see here in small intrahepatic cholangiocarcinoma, negative lymph node had the best survival, about 80%, 5-year survival, and positive lymph node has a survival of about 38%. The other question is how many lymph nodes we have to collect and how many lymph nodes are necessary to define the prognostic significance of this disease. We consider also the number of positive lymph nodes. With 1 or 2 positive lymph nodes, we have pretty good survival. With more than 3 lymph nodes, the survival is very bad. So not only the positive, but also the number, the relative number of positive lymph nodes. In our experience, we collect about 8 lymph nodes each cases. The main question is lymphodenectomy, has a lymphodenectomy a prognostic value or only a staging value? To explain this question, there is a very recent paper published with a French and Japanese group that consider this problem. They consider, with the propensity match score, the patient with clinical lymph node negative. Clinical means is a small lymph node without contrast enhancement, with abnormal shape, without central necrosis. And they compare 2 groups, with and without lymph node dissection in these patients with clinical lymph node negative group. And they observe that in a clinical lymph node negative, we have a 90% of positive lymph nodes. So this is 90% of false negative. And the survival in this patient is significantly different. So in patients that consider negative, clinically negative, we have the best survival if we perform lymphadenectomy compared with the patient without lymphadenectomy. So this is a strong documentation that lymph nodes has not only a staging significance, but also a prognostic significance. The third and last controversy is the recurrence. You know that the recurrence is one of the main problems in long-term follow-up of this disease. And in about 70% of the cases, you have recurrence in 5 years follow-up. The recurrence is more frequent with local regional recurrence and intrahepatic and extrahepatic recurrence. Distant recurrence, lung peritoneal, is less frequent. How have to do with this recurrence? How have to treat the recurrence? You can see here our experience. The surgery is very rare. In intrahepatic, we perform surgery in the 7% of the patient, and in local regional or extrahepatic, only in 3% of the patients. In the other case, we treated with chemotherapy, radiotherapy, or best supportive care. But if we consider the survival, we can observe that the patient with no recurrence, of course, have the best survival, about 60% 5-year survival. The patient with recurrence submitted to surgery can reach a very good survival, very good results, compared with chemotherapy, radiotherapy, and of course, with best supportive care. So, in very selected case, if you can redo surgery, do surgery again in recurrence, is very convenient if you can do surgery and, of course, R0 surgery. I show you a case that we recently treated. This is an old lady. In 2006, we performed a bisegmentectomy of this large cholangiocarcinoma. 24 months later, we had the first recurrence in segment 8, and we performed the second resection. After that, in 2013, we had the second recurrence in segment 6, and in 2019, 13 years from the first diagnosis, we had the resection on segment 7. Now the patient is free of disease, and I show this case because I want to stress one problem. We have to consider all the time the behavior and the biological behavior of the tumor. So we have not to exclude patient to re-resection, but we have to consider and select the behavior of the patient. This is an exceptional case. This is not the routine rule, but you have not to exclude it if you have a good behavior of the tumor. New trends, and very shortly, new trends. The first new trend is laparoscopy. You know that is recently, in 2017, there was in Southampton a consensus guideline for laparoscopic liver surgery, but there, in that consensus, there was no mention on laparoscopic liver surgery and indication for cholangiocarcinoma. This is our experience. We started in 2010 with laparoscopic resection, and our number increased. Up to now, we have about 45% of the cases we treated with laparoscopic resection, not only cholangiocarcinoma, of course, I will show you later. And of about 300 resection a year, 45% of resection is laparoscopic. We start later with intrahepatic cholangiocarcinoma, with the treatment of laparoscopic for this disease. We start with benign disease. This shows our learning curve. We start with benign disease, easy case. Up to now, hepatocellular carcinoma is our first indication in laparoscopic resection. The second is liver metastasis. Intrahepatic carcinoma, we start very late because in our policy, we have to consider the radicality of the surgery. So we have to do the same kind of surgery that we do with the open surgery. So resection, R0 margin, and lymph node dissection. So we start later, and we start with the same principle of indication. So radicality at the first topics of our resection. And I'll show you these few numbers, and based on short recent experience. We operate a very selective case, T1 usually, and we perform also major resection, B-segmentectomy, 12 cases, segmentectomy 8, atypical resection only 9. And I show you that all the patients were submitted to lymphodenectomy with the median number of 7 lymph node resected. So we can reproduce exactly what we can do with open surgery. Selected case with the same surgical radicality. Post-operative mortality was 0%. I show you a short video of the technique in laparoscopic resection. This is right hepatectomy and lymphodenectomy in intrahepatic cholangiocarcinoma of segment 8. This is the patient position and the position of the trocars. All the time, in all cases, intraoperative ultrasound examination. And you can see at the first step of the surgery is the lymph node dissection of the locoregional station of hepatic artery. And we put you can see also along the common bile duct. We tape the right hepatic artery. We perform the lymphodenectomy, also the posterior lymph node station 12P. And you can see the final field of the surgery with the complete dissection of a lymph node that in laparoscopy, we can do this in a very accurate way, and is important because you clean the vessel and you can cut the right portal and the artery to perform the hepatectomy. You can see the Macucci ligament ligation, the right subhepatic vein isolation. You can see that we can reproduce the open technique, the dissection with CUSA. We clip and cut the bile duct, the right bile duct, the subhepatic vein with stapler. Then you control the hemostasis, and you can see the specimen with a good margin and the negative lymph nodes, 0 on 9 lymph nodes. So we can show you this possibility too. And I want to conclude with another new trend, an experience, a recent experience in our center. Usually in advanced cholangiocarcinoma, we treated with chemotherapy with gemcitabine oxaliplatin. This is a case that after 12 cycle had a good response, and we can operate this patient. Chemotherapy, neoadjuvant chemotherapy, may represent a good criteria of selection of the patient that are not resectable with multifocal nodule or big lesion or lymph node positive. And more recently, this is the first case that we submitted to a new protocol called the TOPAZ 1, with association of gemcitabine plus cisplatin, the first arm, and the second arm with the darvolumab, that is the immunotherapy combined in this patient. This is a patient with a small tumor in the segment 6, but unfortunately with a big metastasis in left adrenal glands. So this patient, in our opinion, is not operable. We, after multidisciplinary meeting, we submitted to this protocol, and surprisingly, after 7 cycles of this combination of gemcitabine cisplatin plus darvolumab, we have a complete response of the 2 lesions. This is the shrinking of the lesion on segment 6 and the small lesion on adrenal glands. And the PET scan that we submitted, this is the first before the treatment, and after the treatment, we have no captation in the CAT scan. So we decided to operate this patient just a few months ago. You can see the complete shrinking of the tumor, and here the right lobe, here this left adrenal glands, and we are very surprised to observe at pathology specimen the complete necrosis and no vital tumor cells. This is not the rule. This is our first experience of 7 months ago. But I think that we have to take a look and to watch to this new perspective in chemotherapy, because we can have, in good selection and right selection, we could have a good result, improve the results in advanced cholangiocarcinoma. So I can conclude with to say that surgery up to now offers the best chance of long-term survival. Surgery should be R0 and include, in our opinion, lymph node dissection. And the surgery for multifocal and advanced tumor can offer good result, but in selected cases, you have to perform a very, very careful selection cases. And new regimen of chemotherapy and immunotherapy are in the future probably promising of good results. So I want to thanks again for just kind invitation. And I show you our city in Verona. I hope to see you in Verona, Istanbul, after this very, very severe pandemic. Thank you very much.
Thank you, sir. It was an excellent talk. We came to Verona, I don't remember, but 15 years ago. There was the European HPV meeting.
Yes.
And it's a dream city. I can tell. Hope to see you again there. There are a couple of questions. One is related to place of transarterial radioembolization. Is there a place of this local treatment in case of inoperable case, or to turn the case to an operable case? Do you have any experience with radioembolization?
Portal vein embolization, you mean?
No. Radioembolization.
Radioembolization, no. We do not, we perform radioembolization only in selective case of hepatocellular carcinoma. Cholangiocarcinoma is not well vascularized lesion, so we do not use this protocol in the treatment of, we perform chemotherapy, not radioembolization. We do not have experience. We do not think that is a good indication.
Okay. Is there a place of liver transplantation for intrahepatic cholangiocarcinoma?
Oh, liver transplantation maybe, not routinely, is some study in selective case. You need careful selection, laparoscopy to look for peritoneal seeding. We do not have positive lymph nodes. We have to perform chemotherapy before. There is no big experience on cholangiocarcinoma, but in the next future, due to the good results in antiviral therapy of hepatitis C and in reduction of this indication, maybe in the future, also in Italian experience, the indication for tumor, I mean cholangiocarcinoma and liver metastasis, maybe in the future a good indication. Up to now, in our center in Verona, we do not perform liver transplantation for cholangiocarcinoma, because if it is resectable, we have to resect. If it is not resectable, in almost all cases, as a contraindication also for the transplant.
Is there a role of neoadjuvant treatment in operable cases?
With therapy with gemcitabine plus cisplatin or oxaliplatin or FOLFIRI, the result is not so good. About 25–30% of responder patients. So if we have a patient now with more than one negative prognostic factor, I mean multifocal lesion, big lesion, or positive lymph nodes, we perform chemotherapy, neoadjuvant chemotherapy. That represent a way to select the patient that we can operate it after good response. If the patient is not responded to chemotherapy, also the surgery is not a good indication. So we avoid to operate patient without response to chemotherapy. In T1 cholangiocarcinoma, we go on with resection, and eventually the chemotherapy we will do in advanced modality, in adjuvant modality.
Okay. This is from Ilgin. Do you modify your approach in any way in patients with mixed cholangiocarcinoma, hepatocellular carcinoma?
No, if it's resectable, we have to resect. Hepatocholangiocarcinoma is a disease with a very bad prognosis, and often in our case we have a positive lymph nodes, but if you can resect, we have to resect, of course, these patients.
Thank you.
Okay, thank you. I think this is the end of the questions.
Thank you.
I had a question on screening.
This is a big problem. In Italy, in our country, the screening is just for cirrhosis. But in our country, we have a new disease, this metabolic disease with fatty livers. Yes. And we know that the cholangiocarcinoma may you have also in the normal liver. But we do not have a screening protocol in these patients. So we recommend that to do blood examination, and if you can, a sonography in patient with potentially high risk, that means metabolic patient, obese patient with metabolic syndrome. And I think it is difficult to detect early cholangiocarcinoma. We have only 10% of, in our experience, of early cholangiocarcinoma with incidental discovering during sonography for other cause, maybe gallbladder stones or other case. But up to now, we do not have a screening protocol.
Okay, another question came, so because we have time, I'm going to ask that. Any limit for vascular resection, or it is something center-related question or technique? What is the limit?
Oh, the limit. I show you that the vascular resection, with vascular resection, in this multicentric study, we have 3 times mortality than no vascular resection. And if you can think to have radicality, and if you do not have also another negative prognostic factor, I mean, massive lymph nodes invasion or other lymph nodes involvement, you can do vascular resection. There is some simple vascular resection. Portal vein in right or left cholangiocarcinoma, you can do. We saw the wonderful experience of Japanese and Ebata with the fantastic skills. With cava involvement is possible to do resection of a cava. The difficult problem is the involvement of subhepatic vein and the liver outflow. Because if you have involvement of subhepatic vein, you have very few distance, space to resect the vein. Sometimes you have to put the graft, but it is very complicated. And very often, advanced case with extended vascular resection has also involvement of retroperitoneal space, diaphragm, or peritoneal surface. So we have to do a careful selection of the cases. You have to decide if you can imagine an R0 resection. So you have to go on.
Okay. I think this will be the last question from me. Is there a role of ALPS in intrahepatic cholangiocarcinoma? And what is your experience from ALPS? I mean, it could be colorectal cancer or HCC. There's a busy HPV center. What is your approach to ALPS?
I don't like ALPS. Because ALPS is a fashion, but I can observe many, many deaths in ALPS. So we perform a few ALPS, at least 9 on 10, not more. And mostly in liver metastasis. In cholangiocarcinoma, we prefer portal vein embolization. And we perform ALPS sometimes. We prefer mini ALPS. So sometimes we do limited resection on segment 4 or parenchymal resection, and then we do the second time. We never do portal vein ligation because you can have on the second operation many problems of adhesion in the pedicle of the liver. So in the case that we perform, we do portal vein embolization with the radiological technique, mini ALPS, and then second opinion. But very, very selected case. Small metastasis, the distribution is not possible to treat in one step. But with portal vein embolization, a careful selection with liver function, we use angiotensin green. We don't consider ALPS opportunity to do very often.
Okay, thank you. I'm going to close the meeting and I'm going to give the last word to İlgin. İlgin, son sözleri söylemen için seni davet ediyorum. Herkese iyi günler. Eminim herkes çok yararlanmıştır bu toplantıdan. Görüşmek üzere.
We are grateful to Professor Ebata and to Professor Guglielmi for sharing their wonderful experiences with us. We look forward to hosting you in future meetings. We would be grateful if you accept our invitations in the future. Thank you, everyone.
Thank you very much for your invitation. Ebata, thank you. Nice to meet you. Thank you. Thank you very much.
See you in the future.
Thank you.